My pleasure to be with you all today. And I hope all of you are doing well and your families are safe and healthy. And today we're celebrating a very special occasion, which is the 100 years of insulin discovery. And thanks to the efforts of Frederick Banting and Charles Best, I think today we have people with type 1 diabetes lead normal lives thanks to the discovery of insulin, and they're able to lead a life as normal as anybody else without diabetes. And we have very esteemed faculty with us today. We have doctors, and we have also people who have been winning over type 1 diabetes for the last so many years. And I think the most important thing today is we have to spread the positive message, because there are a lot of myths and misconceptions about type 1 diabetes, about insulin. And I think it's important for each one of us to do our bit to spread awareness on insulin, and basically try and bring facts where there are so many myths. And today also we hear about spiritual gurus who are saying that we can cure type 1 diabetes and you don't need to be on insulin. And we know that these are tall false claims, and people can land up in problems, especially if our children go off insulin. They can land up with diabetes ketoacidosis, and this can be really serious. And we do not want any of this, especially during these pandemic times where it's so difficult to even get hospital beds and get access to treatment. So I think each one of us has to do our bit. And I really would like to thank Indrajit and Dr. Basu for coming out with this very, very important program to discuss insulin, and have people who are living with insulin, taking insulin, because a lot of people come and tell us that, does insulin have side effects? If I take insulin, will I get addicted to it? And there are so many myths and misconceptions around insulin. And we really like to hear people who've been using insulin for so many years, share their journey and tell us and reinforce that insulin is safe, and we can go back and help our patients live a happy life with diabetes and win over diabetes. So at the outset, I'd like to request Dr. Basu, who's the president of DAY, to speak a few words, introduce the program, and also introduce our esteemed guest, Professor Azad Khan today, who's with us all the way from Dhaka, Bangladesh. So request Dr. Basu to come and address the audience.
Thank you, Cheryl. It's a pleasure to see Cheryl and, of course, all our good friends and the dignitaries that we have today for this seminar. In fact, we are actually trying to celebrate the 100 years, the journey of insulin. We all know about Banting, Best, we know about MacLeod and Collip. We do not know about exactly what happened in those 2-3 years in the lab in Canada, or whether it was a movement from Canada to England, what were the emotions, what transpired between the typical politics, the lab politics, the doc politics. There is a wonderful book by Michael Bliss, which talks about this journey of insulin. And there's so much drama in that book. I think there are small snippets of that narrative which have been made into films. But today we have all collected, because 17th May, technically, we know that 7th of November 2020, the great minds, they came together. Banting came forward and to MacLeod's lab, and then he met Best, who was given to help him out. So they put their minds together and began to work out a plan. On 17th May 1921, the experiments actually started. So MacLeod actually provided Banting with the lab facilities needed to conduct their experiments, and brought in a research student, first year research student, Charles Best, to help Banting out. Now, Best actually specialized in testing blood to check the glucose levels. And that would be the only way they would know whether the insulin extracts were having any benefit. So on 17th May, what happened was Banting, Best, and MacLeod, they first got together to begin their research and set about figuring out how to remove the insulin from a dog's pancreas. Their method was basically to tie off the pancreatic duct and to kill off the other substances in the pancreas that would destroy insulin, but would leave the islets intact. The remaining extract would then be given to other dogs who didn't produce any of their insulin because their pancreases had been removed to work out its effects on their blood sugar levels. So this was the methodology, and the whole program started on 17th May. So Indrajit, called me up and said that let's have this program, the first journey of the 100 years of insulin from May onwards. And as we, roll forward and fast forward during the time to 2022, we'll keep on having a lot of programs. Yeah. And before we start, of course, day is all about diabetes awareness, and I personally would be privileged here and would take the responsibility to introduce, I think a guru of this time. Talking about diabetes, this is a name that you reckon with. Had it been, 100 years back, of course, it was Banting, a man who had discovered the magical molecule called insulin, which is as important as air and water. And they didn't do a patent. He gave it to, the company, to the University of Toronto, just at $1. It was bought out then by Lilly as the Iletin, and they developed into the, professionally what we sell as insulin today. So he's none other than Professor A.K. Azad Khan, sir, the president of Diabetes Association of Bangladesh. And of course, he has got accolades one after the other. As we say more, we would actually not be doing real justice to his merit. But what I would like to mention here is that he's, in the recent past, been the honorary dean of the Faculty of Unani and Ayurvedic Medicine, and has keen interest on developing these, natural products, so the nutraceuticals, to come into action where pre-diabetes can be stalled, or the complications of diabetes can be arrested. He is a phenomenal man, and I, as I said, I was almost virtually comparing him to Dr. Banting, because during his doctoral study in Oxford, he invented a strong part of that inventing team of the 5-salicylic acid, which is, of course, the key drug for the inflammatory bowel disease. And it's quite a fatal disease, but this drug revolutionized the chapter of treatment for IBD. And he did not patent it so that it can, become freely available to the public. So that is the link that I was talking about. He has been nominated in various, positions across the world. He has won the best, first Global Leader Award in the IDF Vancouver. He initiated actually the UN Day, the UN Resolution Day, 14th of November, for diabetes from Bangladesh represented, and on his request, the government of Bangladesh raised the issue in the UN in 2006, and we know the latter part is, of course, what is history. We have 14th November as the World Diabetes Day. He received the Independence Day Award from the government of Bangladesh for social services, and this is, of course, the highest national award, like Bharat Ratna in India. And very recently, in the first week of May 2021, the Ministry of Education in Bangladesh has appointed him as the national professor for 5 years. So he is now credited to do a lot of more work, and he's supposed to get a lot of funds and free access to continue work both in all across the world. And I'm hoping that we will collaborate with him shortly. So without further ado, and I think talking about him, we can spend days and perhaps months together. And a man with a vision, far-sighted, really a man who started this, marriage, the counseling, the preconception counseling through the qazis, the marriage registers for Muslim, Islamic marriages. So there, while you're actually getting the marriage, the solemnized the ceremony, you also the qazis make sure that they talk about in that very special moment about the conception methods and of course the safe conception planning if the patient has diabetes, or to at least rule out diabetes before and or during early trimester of pregnancy. And that can actually save a generation of the offsprings to be suffering from diabetes, obesity, and cardiovascular disease later. So thank you, sir, for being here. Pranam from all of us.
Insulin is a hormone which is essential for life. This is something to appreciate, that all hormones are needed for normal life, but all are not essential for life. All are not, like testosterone. We castrate bulls, so for plowing land, but they don't die. They don't die because testosterone is not essential for life, but insulin is essential for life. So before the insulin was discovered or insulin was found, people with type 1 diabetes, they had no other option than to die. So insulin was such a momentous discovery, and this you see the credit goes to Benting, that he was able to extract insulin from the pancreas, and that altered so many things. And we are celebrating that centenary, because it was in 1921 on this. And I think insulin should be declared as a human right issue. And I can say in Bangladesh, we have been able to persuade the government of Bangladesh to declare insulin as a human right issue for type 1 diabetes. And government has publicly declared that they will provide insulin to all type 1 diabetics in the country. I think this should be followed by all countries. And in fact, this year, in the World Health Assembly, there is going to be a proposal on this. I think Russia has sponsored it, Norway has sponsored it, and many countries, including Bangladesh, has co-sponsored it. I think that's all I have to say. Hello.
Sir.
Could you hear me?
Yes, sir. It's a great, that's what you have informed, that it's a great issue or what Bangladesh government has adopted. In India, we are still struggling with that issues, with the rights of the type 1 diabetes. So, sir, thank you, sir, for your precious time. Actually, sir, we have our one of the panelists, Mr. Nodes Gopaldas. He is from Ghana. He is using insulin for the last 55 years, sir. Last 55 years. And we have Ankita also. Ankita is using insulin for last 20 years. So they all need your blessings also, sir. And we are celebrating these 100 years of insulin, Dandi of insulin. Now Cyril are also there. Cyril.
Yes, Chandrajit. Thank you so much.
In fact, if I am allowed just one word, this, sir, very important and everyone, Ankita we're talking about mucormycosis, right? Ankita, at the age of 13, when she was diagnosed with, I remember rushing into the ICU and I was shouting, her parents were there. Who has got this sugar? I mean, where does this sugar smell come from? Obviously, we're talking about acetone. And I remember now Ankita recalls because her parents told her that. So, and I stood beside her, and because I got an information that there was a girl who crashed and she was breathless and she was brought into the ICU. So I was in Noti and I drove very fast, and I remember I was panting but in the ICU I was shouting, "Who has got this sugar?" I mean, then obviously she was having this breathlessness and the lungs were filled with crepes and all. Then I asked immediately, let's do a sugar. So the random sugar came as high, and the blood sugar was immediately sent for lab investigation, which showed somewhere more than 880. I don't know whether Ankita has joined already. And then after that, we were struggling with her lungs. We thought this is a typical case of tuberculosis, but one lung got completely affected, and the other lung was being, gradually, it was, kind of eroding into the other lung. At that time, I became very panicky, and that was before our class 10 exam. And we wanted to do a biopsy. In the process of doing the biopsy, we somehow there was a calamity. There was the pulmonary artery ruptured, and she was taken into the cardiothoracic OT. A 7 hours operation was done. Right now was sacrificed. So she had a pneumonectomy, and then she appeared her final exam, and that was in 10. And this diagnosis of that disease was mucormycosis. So she had, at that time it was the 12th. We had only 12 reported cases in the world, and I think she was perhaps the 13th, which went unreported. And before she was 12, she had a right, papillary necrosis of the right kidney, and then also she appeared for the exam and became qualified as an engineer, and now is one of the big guys in Capgemini. So this is the positive part of what we are hearing from mucormycosis.
Mucormycosis is an old rare disease. Recently, we had 3 cases, all uncontrolled diabetes. You see, none of them had COVID. And 1 died and 2 recovered. But I think people should be aware of it. There's no need to be panicked. So it's not. It has created panic now. Anyhow, I think to come to insulin in the this issue, that insulin is a human right issue, that needs to be emphasized. Because how else a poor type 1 diabetic will survive? See? How else he can?
Yes.
Developed countries where there is universal health care, so they are covered. But countries like poor countries, I say not poor, whatever, they are developing countries, where there is no universal health care, the poor person has type 1 diabetes, then how else is he going to survive? He survives on charity. But interestingly, if type 1 diabetes can be correctly detected and correctly treated and correctly trained, they can lead virtually near normal life. Like you have mentioned of some people, but one person who became the judge in the Internal Court of Hague. See, I think he also became a Chief Justice, and he was the Pakistan's first foreign minister, Jafrullah Khan, and he had type 1 diabetes, and he lived pretty long.
Yes.
Sir, actually, in India also there are a lot of instances where the people living with diabetes with insulin, type 1 diabetes, almost 100 years, sir.
Yeah. Well, Wasim Akram.
Yeah, sir.
Great all-rounder. One of the bowler who did who had hat-trick twice.
Yeah.
Was hat-trick twice. He is a type 1 diabetic.
We know, sir. Sir, and past Prime Minister of the England,
Theresa
May. He was also type 1. And nowadays, very popular, sir, in our country, the husband of Priyanka Chopra, Nick Jonas.
Nick Jonas.
Nick Jonas is also type 1. And we are also here one hero and one heroine here. Mr. Nodesh Kukuldas from Ghana. He's also our hero. He's taking insulin for last 55 years. I think Nodesh Mama, please
Yeah, I think we should
tell us. Yeah, tell us
would,
your journey, sir.
yes, our most energetic and young man living with type 1 diabetes, a true
Okay,
inspiration.
so
And I think,
I ever met.
yeah, we
I'll come in
always
with
give you
that
an example.
I'll come in with that and say, hey, here I am, this 61-year-old guy living with 55 years of diabetes.
Already, actually, Mama, insulin done the century, but you have already done the half century.
Yes, so you should share your journey with everybody and give us your pearls of
Hey.
wisdom.
I've spoken of this a few times in the past, but I'm speaking of it now. It's at that time, hey, this part of the world, we're in Ghana, West Africa. But before I go ahead, I wish to acknowledge what Dr. Khan said with respect and the efforts that have been put in where Bangladesh as a country, which of course is not very wealthy, neither is it poor, has achieved things under his fight, if I may put it that way. And Dr. Khan, my salute up to you and hats off to you for whatever you have done for this world for diabetes. I bow down to you and highly look up respectfully at you.
I don't think I have done too much. I only created awareness.
Yeah, but still, that is what takes it on. I mean, without that awareness and without those efforts, nothing would have happened. Nothing would have happened. So once again, we bow down to you, sir.
For a government in developing countries, it doesn't cost much. Because type 1
Yes.
diabetes is not common here. Type 1
Okay.
diabetes.
My story, of course, 1967 was the year I fell ill for a couple of months without being able to be diagnosed properly. 67 in Ghana, this was something that was unheard of. It was my last 3 days, I think, well, at least the last doctor we saw told my parents that had you not brought your boy here, in 3 days you would have lost him. I would have gone into a coma. And yes, there started my journey, April 1967, with diabetes. Of course, it obviously meant that I actually had it earlier, but it was then diagnosed and I was immediately put onto insulin then. And yes, in those days, mind you, injecting insulin by yourself, I was too young to do it. My father ultimately, with a big heart, agreed and was taught. But yes, that's what my start was. It was a whooping cough that I started with, a bad cough that was initially treated with penicillin injections. But then later things just kept changing, getting worse, till I was diagnosed. And hey, thank God I'm still around. I'm very much here. I try to be as energetic and humorous as I can in life. I am that kind of a person. I think I have a few to agree to that.
You still young.
I'm sorry?
I said you still look young.
I'm looking forward to meet you, sir.
Okay.
So yes, the journey has, I won't say it's been a bed of roses. There have been ups and downs. There have been learnings. There have been teachings. I thank God I led a blessed life. My parents played the most important role in the early stages. I would also say my siblings played the role, and then came in, of course, the most important person in my life, my wife. But yes, having started with injecting, initially it started with the arm, it went to the thigh. I had certain other health. I developed jaundice at a young age, which is what actually hit me or allowed me to become an individual at the age of 15 who could start injecting myself. Prior to that, for that many years, my father was injecting me, and he would sometimes leave work to come home just to inject me. And that is what hit me. And I said, hey, I must start doing this myself. Even he convinced me and made me understand. And yes, my mom couldn't do it, I must say, at that time. But yes, dad, and one of my brothers, my elder brothers, also helped me a lot in life, I must say. So, yes, the journey. Otherwise, at the tender age, well, I won't say tender actually. No, I was a big naughty boy by then. 24 is when I got married. I am blessed with two girls who are also married. The, the side of insulin, I did no doubt used to have challenges with availability of insulin in this part of the world with such a rare disease. But my dad used to manage and fly down from England, which was our main connection to the outside world with Africa. And insulin used to be flown in, of course, very carefully in cold packs with individuals who would fly down as family and friends and help us to carry down for us. Otherwise, there was no common availability of insulin in our part of the world in those days. So we went on. My father kept guiding me, teaching me. I went through a phase of having certain health challenges with some minor surgeries that took place. Healing sometimes took longer, but hey, I learned more with time. I understood more with time. And I must say I've led a most normal life that anyone could ever wish to live. There's been there's been no such thing that where I could say because of diabetes I couldn't do this, or because of diabetes I couldn't do that. Everything. In fact, I look up to that Almighty and thank God for the fact that I've lived an absolutely normal, healthy, good life till now, and I continue, praise to be so, till whatever time is there. In 19, well, no, I'm saying 19, forgive me, 2016, 17, when we were lucky to connect with Dr. Basu, I met him 2000, late 2016, early 2017, with respect, Dr. You. And that's when started another journey in my life of diabetes. I, of course, by then was diagnosed with some heart issues, which were taken care of. I put it in a most simple way. I had an open heart surgery. But yes, everything's been smooth. And thank God at that time, under the able guidance of Dr. Basu, I was put on the Medtronic insulin pump. And ever since, my life has improved even more. I would like to add recently that I had quite a serious COVID situation, both my wife and I. And of course, again, under Dr. Basu and our local doctor's guidance, I was well taken care of. I had to be put on remdesivir IV. But yes, I fought it and I made it through. So currently, I keep adding my life has been the best I can ask for. Diabetes can easily kill if not taken care of. I'm not denying that. But at the same time, once you take care of yourself and you are guided well and are willing to do it in the right way, oh, you could live more than a normal life. I definitely will like to add, Dr. Khan, especially to you, as you mentioned earlier, sometimes levels of not being of able to afford the medication becomes a big challenge in many lives, especially recently. Now, recently, because of the upsurge in diabetes, it is something which I pray and hope eventually the world will look to in a different way. I loved it when I heard it's more like air, as mentioned. Oxygen, you can't breathe, you can't live. And that is what insulin is. So to this 100 years of insulin that I must be honest, till very few days ago when I was invited, and I'm honored to be here, about the fact that insulin is 100 years old, even being such a long-standing diabetic, I did not know. I'm not even, should I say, bothered to actually go to Uncle Google, as I call him, and check how old insulin is. To me, insulin is life. And I continue to say, without it, we'll not be around. I think I don't want to take too much more time. I've shared the little and the in and out of my life. And please, I'm happy to answer any questions if anyone has. But I'm always available. I wish I could be even more often. Unfortunately, COVID has not allowed us traveling for the last 1.5 years. I was meant to have been in Calcutta maybe twice during this 1.5 years, if not thrice, but definitely twice. And yeah, that's it. I'm here. I'm living. I'm fine. I'm up and laughing.
Mr. Naresh, you should also tell them
I
about
can't
the
hear you.
devices that you are on, 54 years back and today. So you said you're on the Medtronic pump, but I'm
Yes.
sure when you started out.
Oh, when we started out, it was that very tiny, small sterilization pot. Boil your needle, boil your glass syringes, make sure they were sterilized, and then draw out the insulin from the vials of those days, which there was, I mean, with particularly from the time I learned, of course, I think back what my dad went through, but from the time I learned and the time that we had to be so careful with the insulin drawing, the bubbles, those glass syringes that had to be sterilized, what used to happen at that time is the needles used to be a challenge, the sharpness of the needles. After a short period, they used to become very painful while injecting. And we used to keep replacing those, but we also had challenges getting those in those days. Finding when the best quality in those days used to come from Japan. My dad used to specially organize that to come in from Japan into Ghana, because he also learned, he learned through books. Mind you, it is not today what we are with the technology we have today. You just go to click on, you find people. I mean, for him, I can imagine what a journey it was with me, because we were 5 siblings, 1 sister and 4 brothers. All the others are fine meaning they never had diabetes. Mind, we believe today, when I was later told, is the infection that I'd had, probably through its viral form, actually damaged my pancreas. Yes, so then from that time, then came in, Cheryl, especially I'll answer your question. He came in the time when we started going onto these daily insulin syringes, which disposable, use and throw. But even at that time, to get those out here was so difficult that I'd use one for 2 days because it was just me using it. So I'd store it in a fridge the minute I started using it. So I would averagely use 3 to 4 1cc syringes every week. That is what ended. Hey, then came the time when I went through one more phase where it was a special instrument where the syringe would enter. It was like a gun. You'd shoot in the needle so that the pain was very little, and then inject through the syringe. And then finally the pen. This is the stage that I went through. Cheryl, I can't hear you.
Sorry, I'm on mute. I said those were the jet injectors. The one.
Correct. the jet injectors. But to be honest, I was never comfortable with that. Although my dad got it for me, within a month I said, you know what, I'm not interested in using this. I prefer the other. I used to call it the simpler way. Get it out with.
Mama, still you possess that things. Do you have?
Sorry?
Still you possess that thing? That thing?
No. I don't even know where it is.
Then I want to use as a gift from you.
I know there is.
If I ever find it, I'll definitely, although I doubt very much. I don't think even my wife Jyoti saw those. Those jets were they never lasted too long.
The jet injectors were like, and not very complicated. It was a delivery device almost shaped like a pen, and it had a nozzle, a disposable injector nozzle. And then you also have that vial adapter. So basically, it was to take in from the vial. So all three put together, the tiny opening at the end of the nozzle would measure hardly, very small, very small.
Yeah, very small, but still it was the same needle we used, that traditional glass syringe needle, sorry. So those used to get blunt very, very quickly and very painful.
And those needles were also very
spiral kind of.
Big. They were thick and they were long, so it was quite scary also. Today you have such fine needles with, they're so small that you can't even feel the prick. So life has definitely become better for our kids thanks to, so much of advancement.
Yes. The first time I saw that disposable 1cc syringe, I actually asked my source, I told him, yeah, this looks more like a dental syringe. Are you sure this can even, it is so fine, can I even use it? And he said, yes, of course. And I started using, and it was,
right. And since we have a lot of educators,
no pain.
Right. I think for all the educators here, I think this is so important because, at least because that's the biggest barrier, the needle. And if you can get them to inject in front of you and tell them that how pain-free it is and it's not so, it's not so difficult, I think that whole fear goes away. And that's why the first insulin injection preferably should be either at the doctor's clinic or in with the diabetes educator, because
correct, absolutely.
Yeah, so and then they feel, oh my God, it isn't such a big deal, it's so good. And then people, even those who do not have type 1 and are put on insulin, like the type 2s, they prefer being on insulin because they feel their life is so much better, the quality of life is good, and their glucose control is so easy, and they have so much flexibility. So I think it's all about that just one, the initiation, which is always a challenge.
We should also thank God today we have such different types of insulins where the medical fraternity guides you and knows what is best for you. All these advancements have made diabetes management so much better, easier, controllable, everything better, and hopefully things will get even better. Time will one day bring something where it'll be like taking a tablet, hopefully.
Correct. In fact, in the past, when there was only premix, it was so difficult because it was so rigid. There was no flexibility and you had to force. And you
But Cheryl, I'll
feed for the insulin. It was always about feeding and ensuring that the person needs.
I must add this also. One good thing with today's time and the education we have, thanks a lot to the educators and people like you, Cheryl. The only thing we knew in the old days was what is sweet you avoid, what is not sweet you have. We never understood the effects of what is not sweet, yet so bad, once it goes into you. And that's why the GI, which has come in, and things that, we understand that, I particularly put it in this way, anything that is white and powdery, whether it's salt, whether it's white flour, whether it's drugs, I put it in that way even, or sugar. So anything that is white and powdery in this form generally is not good for the body. And this is what it was. Eat anything that is not sweet and avoid anything that is sweet. That is what we understood from diabetes. Perfect. I've done and given my version. I'm open to anything to be asked, anything to be told.
Now I want a question from Ankita to Naresh Mama, actually.
Yeah, sure.
Ankita.
Thank you so much. I think it's wonderful. I mean, there's so much that we can learn. And I think today's generation should just, I mean, to listen to you is great, because then we know how blessed we are in terms of, like you said, you know,
Ankita.
the insulin, the types of insulin as well. Today you have a whole range of it, and you can lead a normal life just like any other child without diabetes, because you have the flexibility of eating when you want, not eating if you don't want. And with basal bolus, it's become so much easier. And if you're on the pump, then even more. It's but you have to use the pump the right way. And like I always tell people, if you're going to use it just like a phone, just to take a call and disconnect a call, there's no point of being on a pump. You really need to use it and learn and use all the features to be able to manage your diabetes well. So thank you so much. Is Ankita there? And Ankita, you can ask your question.
Panel. My wife wants to come in. Jyoti, who you many of you know.
Yes, most welcome, most welcome, most welcome.
Most welcome.
Good evening, everyone.
Hi, Jyoti. How are you?
Fine, fine. Thank you. I actually just came to thank you all for introducing the pump into my husband's life. It has really saved us from so many complications in his life. And especially Cheryl, the way you explained us, take insulin when you need. You don't need to just pump in all at one go. Take as you eat. So that has really taught me a big lesson that actually I can calculate his each and every unit what he eats, but I prefer when he eats in front of me, not hiding from me. That's so thank you all so much. And I think it's a blessing for everyone. Whoever can afford this should go to this insulin pump. It's a blessing. It's a big blessing. Thank you, Cheryl. Thank you all.
We hope all people with type 1 diabetes get spouses like you. I think you all are the backbone, and you all are the reason why we have people like Mr. Naresh and everyone leading such a good quality life. And I think that's so important.
I mean, all we diabetics, type 1, need one Hitler. Thank you all. I'm very much.
But she's a good Hitler. She also wants to feed you, and she's always checking with.
Oh, she does. She does. She does.
Ankita, are you there, Ankita? Yeah, she's wonderful. She's so involved, and that's the best thing. I mean, it's amazing. Ankita?
Yes, I'm here.
Yeah.
No, I didn't have a question basically, but I would request him to document his story, so that we can I mean everybody can read it up for an inspiration. So
yes, I think I'm going to reach out to him, and we're going to get him to do a video about his journey. I think it'll be great, and that will be a very good treasure for all our future generations. I think it'll be very important, because they also need to know how blessed they are, and they're in a generation where everything is there available. And the kind of hardships that you're faced, and you're still so happy, and you'll still manage to do well. I think that's so important.
I would like to add one little thing, with your permission.
Sure.
My life in school, especially when I was diagnosed, so I was in class 4. So it became something where we had break times, as all schools do. And generally, children, unless there was a particular reason, were not allowed to just get up and want to go out and go to the bathroom to use it. So when my parents came to meet the principal of the school and my class teacher at that time, by which time this was a very rare situation in children, I must say the schools also need to get some education about particularly young type 1 diabetics who need some assistance when they come to school. Because I cannot forget that teacher of mine who was so understanding, and it's wonderful the way they all took care of me. she even gradually, as other students, friends, got to know all the help, all the willingness to come forward. This school issue for young, growing up children, I was given all the liberty. My teacher told me, look, without taking advantage or anything, anytime you wish to go to the washroom, just get up and go. Don't even ask me. Of course, as a respect, I would always tell her, ma'am, I need to visit the washroom. But what I'm trying to say is that school played a big role also. Growing up in school and having this, while most other students, no one, I don't want to say most, at that time, as far as I was concerned, I was that unique one. So it's something which we should all keep in mind, where parents should also be educated for the very young type 1 diabetics to go and meet the principal or the teachers and let them understand about their child, so that if there were any differences or noted issues where that particular child, or nowadays I'd say few children, teachers should understand it and know how to handle it.
I
This
agree
is please
completely.
something I wanted to share.
I always tell parents that, you should inform the teachers. A lot of them don't want to, because they don't want to, that there is a stigma attached. And I tell them that you should inform the teacher, the principal, the friends, who are always there with your child, because it's important. What if the child goes into a hypoglycemia? Or I think it's important. I think awareness in schools today, we should do it, because it's so important for them to, know how to deal with these children. Not let them feel that, any different to a child without diabetes. And I think that's so important, whether it's your coaches, when it comes to sports, or your teachers or your friends. And acceptance is very, very important. Making them feel, one of you is so, so important. And I think that's something that we should do even in our country and in your country, where we should try and educate more teachers and, people on how to, deal with children, and how to, I think it's important for them, because these children go through a lot of difficulties, especially in school, because I know so many kids who are not allowed to pursue sports because they have type 1 diabetes, and they're not, allowed to participate in a lot of things.
Oh, I must say I was allowed everything and anything. I did everything I could possibly do that a child wishes to do in school. There was nothing that I was not allowed to do.
That's fantastic. I think there are a few schools, but we have a few schools which do not allow you to check your sugars. They don't allow you to, take insulin, because not every school has a nurse or, the first aid room. And so we do have such schools, but I think things are definitely getting better. And all we can do is maybe spread more awareness, at least as educators or maybe parents of children with type 1 diabetes, at least in the school that our kid goes to, try and, create that awareness. I think it's so important. So thank you so much. It was, as always, wonderful having you and seeing you. It's always a pleasure. And now we have another very, very young, enthusiastic, energetic, I would say the man with the biggest heart, my most favorite. He has so much. I mean, he's doing such wonderful work, not only in Kolkata, but across the country. And he's none other than Dr. Devashish Basu, the president of Diabetes Awareness in You, and a very senior consultant, working, so closely, even today in the COVID times, working so much with, people with COVID. And it's amazing to have him here. And we'd like to hear from him about the challenges, the barriers, and the way forward when it comes to insulin therapy. So over to Dr. Basu. Thank you so much.
Thank you. Let me take a deep, long breath. And that was a huge, and a pile of accolades on my head. I think I can do some merit to it someday, but I need you always, on my left, closer to my heart, so that we can do it together. Now, I have this task to talk about the barriers, and I think all my educator friends, patients who have joined, it's just a brief overview of what general kind of diabetes is. We need to know that the burden of diabetes is something that is so overwhelming. When we talk about, we always keep, making claims that the diabetes, the burden has placed on the healthcare system is a result of increased morbidity, mortality, the economic costs, and it just continues to count on and increase you previously used to say each decade, now it is almost every year. Type 2 diabetes starts as an insidious condition characterized by defects either in insulin action, where the insulin is there but it cannot do the proper action of converting into its storage molecules, or there is simultaneously a problem with the insulin secretion, as we saw with our Naresh Dada and my daughter Ankita. So this is a different type 1 part, and in fact all the type 2s have simultaneously both insulin resistance, where insulin is there but cannot work properly, and because it cannot work properly, there is excessive release of insulin to meet that demand, and gradually the beta cells give way and function if there is loss of insulin. So effectively, when you are considered to be a proper type 2 diabetic or a person with type 2 diabetes, then you have both the conditions together. So, and then you cast its ominous shadow very stealthily in a pernicious process to disengage all the cells of your body, the living body, from the intended functional purpose of their actions. In order to minimize these risks of diabetes complications, we know effective therapy involves, of course, lifestyle change and many drugs. So, indeed, the prospective randomized controlled studies all across the world clearly tell us with unequivocal evidence that there is benefit of very good, tight glycemic control early in the course of the disease. Maybe that through the intensive treatment, maybe that through the mechanism of insulinization and that will improve the health outcome, have a lot of positive metabolic memory with good glycemic legacy for all the people with diabetes. And to maintain these patients to the goals earlier in the disease process is something which is very important. So thereby we need to understand that insulin cannot be treated as the last resort. And that is what happens generally with most of the patients all across the world. Insulin needs to be instituted much earlier in the disease process, of course, in type 2 diabetes, because in type 1, the only answer is insulin, as a part of the individualized preventive treatment strategy. So earlier you have insulin, earlier the control is better, you have less chances of complications. And early insulin improves your beta cell function. It also puts you onto a kind of a remission from the hyperglycemia compared with the treatment that is conventionally with other oral anti-diabetic agents. And of course, we now have much introduction of these newer therapeutic agents for glycemic control, which offers very broader view of pleiotropic actions on heart, kidney, and it also raises questions in the clinician's mind as to whether they should now think of insulin, whether actually people will need insulin, or whether these SGLT2 inhibitors or GLP-1 receptor analogs, which are there, they will do the magic. But let me tell you, ladies and gentlemen, I'm in the practice of diabetes for, so Ankita is my baby, whom I've been kind of, blessed to take care of when she was 13. Now it's almost 20 years that I've been taking care of. And we are doing it very well. We understand that with insulinization, we have seen the lives which are still there, alive with us. The only problem in this country is that there are a lot of various forces which keep us opposing and delaying the starting of insulin. And the lag time between that insulin is needed now and the insulin, when it is used, that lag time is called the clinical inertia. And this clinical inertia is killing the world. I mean, it is much worse than what we talk about, COVID and the, happy hypoxia. I think we are in a state of happy clinical inertia where we fail to realize that the man is actually dying, not knowing that, insulin could have done wonders to that man. I mean, pardon me for all this, gory language, but, it comes from the heart, truly from the heart. Question is, why insulin? So the ultimate goal of glycemic management is actually to safely achieve and maintain glucose and energy homeostasis, which is close to normal, near normal levels. And finally, to slow or even prevent the complications of hyperglycemia. And we know the macrovascular complications of heart, stroke, peripheral artery disease like amputation, or the microvascular like retinopathy, neuropathy, nephropathy. So all that, these complications can be actually stalled, completely. I won't say it will never come, but if you are not doing the right, correct, management of glucose or the glycemic control, perhaps it will come in 5 years. Whereas if you are taking good control, it will be delayed. It will come 25 years later. The whole question is early use of insulin will actually reduce the chronic lipotoxicity. It will increase the rate of beta cell, apoptosis and the deterioration of beta cell function. So these all will be reduced. And finally, if you all know that this is the curve, please, everyone in the whole world, look at this curve, because type 2 disease is the disease of the world. Everyone, if you have not yet got diabetes, you are still equally prone to have diabetes. This is what happens, insulin resistance. A lot of all these biochemical hazards, the psychological stress, they give rise to this condition called insulin resistance and obesity, etc. And this keeps on rising. As it keeps on rising, there is extra flogging of the beta cells to release insulin. And the day you are diagnosed as a diabetic person, your 50% of the beta cell function is actually gone, and it keeps on going downhill. Finally, by 10 years or so, you have ultimately no insulin reserve left in the beta cells. Every year there is a 6% decrement naturally. That's a natural progression of insulin in the body. So if you know your pathogenesis well, if the patient, the educator, and the doctor, three of them, all the stakeholders, know this progressive nature of diabetes, majority of the patients who will finally require type 2 diabetes, I'm talking about, will require insulin therapy, will not wait, but will come forward and ask the patient, doctor or the educator, that this is time, please, 5 years, please put me on insulin. So this is something that we need to basically change the climate of insulinization or diabetes management in the world. Insulin therapy, therefore, is frequently or unfortunately always delayed and is deemed to be the last option. And it is being always considered as a threat. Well, you couldn't do this, you couldn't meet up to the challenges of your getting your numbers under care or control, then you have to be put on insulin. That approach is very irrational. That approach is wrong, because you have to be put on insulin because there is a natural waning of insulin secretion in your body. So if that is made clear early in the course of the discussion of a shared decision making between the doctor, patient, and the educator, things can be easy for all of them. And we know that addition of insulin to the regimen actually will actually reduce a lot of cost of treatment. It will aid in attaining and maintaining glycemic control, and therefore it will not lead to progression of complications. One eye complication, and the person immediately in the next 3 months to 1 year spends around 5 lakhs and not sure whether he'll get back his vision. And if you are taking good control with your insulin right from the beginning, you will never land up in such a state, perhaps. So these are the areas where we need to understand, all of us, that insulin is very important. Exogenous insulin resistance, that you put in insulin from outside, not endogenous. Whenever we talk about insulin resistance, we talk about the endogenous, within the body, what is happening with too much of insulin being forced to secrete. But exogenous is when we are putting in insulin from outside, and what happens is the patient immediately has a psychological insulin resistance called PIR. But I believe the greatest insulin resistance is in the mind of the treating doctors. And we must understand that any kind of diabetes, whether type 1, complete insulin deficient, or type 2, relative insulin deficient, we need to actually give him insulin at some point in time. The earlier, the better. Therefore, I always think, and I always cry aloud and say, my God, it's the physician's physical initiation reluctance that is the PIR, and not the psychological insulin resistance of the patient. So I, as a doctor, have to be fully geared with the knowledge of insulin, the mechanism of how I do my insulinization, the mechanism of how how my Cheryl takes care of this journey of the patient, and the whole mechanism of, as Norris was saying, Jyoti was saying, the carb count, the whole, the whole chemistry of it. It's a pure alchemy. And once you have learned the trick of the trade, you can never go wrong. So you have to now identify the barriers. Yes, insulin gives you hypo. Insulin is costly. There is problem with, different times and school. You have to, get up from your regular working, school hours, take a shot, and you also have to take a meal around that time. So there are a lot of tweakings and changes you have to adjust. But if you have a good school teacher or a nurse who has been educated, then it's not a difficult task. The dose titration initially is difficult, I'm sure. All of us agree. But then again, it falls in a kind of a gradual role, natural kind of a routine model. We know that when we talk to the patients about insulin, suddenly at one gatsu, the patient might run away. So you lose one client and he will not come back. When we talk about the patients, every day, the patient will say, "Pratidin nite hobe, every day nite hobe. Will I have to take it lifelong?" These are the questions that you obviously come to confront. But if you have trained your patient right from the beginning well, then I think these are just not problems. We have to overcome barriers. We have to understand that there is a fear of hypo, there is a fear of weight gain, there is a fear of needles called, it is called trypanophobia, belanophobia. That's always there. And there is a fear of impending doom with insulin. That the moment you are started on insulin, your lifespan has shortened, and there are only hardly few days, the counting. And of course, people say that if you are given insulin might cause atherogenesis. You can have more heart attack. You can have a retinal hemorrhage. These are kind of myths and misconceptions that we need to clear at the earliest. And then in the inconvenience, keeping it in the fridge, how many injections, whether you're moving, whether you're having a long meeting, how can you do it? The frequency of your tests, and of course, the quality of life. That is the most important, fundamental, crux of any management. We need to know whether you're an executive or whether you're a sweeper or a janitor, you need to have a happy life. And that serenity and the calmness should, be from within. And you have to adjust whatever you're taking your insulin or having your food. They all have to kind of amalgamate well to finally achieve that quality of life. Non-compliance, whether your family agrees, you're married into a family where your in-laws hate to see that you're on insulin, and where you're taking it to the toilet and doing it at wrong times, and your meal is not served because your in-laws place. So these are the non-compliances, kind of challenges that we need to, straighten out. And of course, cost in our country. If we are looking at those, the designer insulins, they are costly. There are indications where we need to know that the patients who are on high dose of oral tablets and they are not being able to meet the glucose levels, don't waste any more time. If the patient has these serious catabolic insults like ketonuria, weight loss, or severe hyperglycemic states where you're running to the toilet and you're losing your energy, it is very evident from the face of the patient. The intercurrent illness, like COVID times, no, nothing else, just insulin. Surgery, trauma, infection, fever, pregnancy, of course, and nothing but insulin. And if you're less than 10 years of age, and you are type 2, if metformin or other insulin resistance medicines don't work, you can safely go to insulin. And why not? Because even, beyond that neonatal diabetes, where orals help, at any point in time, beyond 8 months of age, a person can be on insulin, we know. We need to know the doctor's attitude, that the patient won't accept insulin, the patient will change the doctor, the lack of time for consultation and the educator engagement to teach the basic facts and the benefits of insulin. The worry that you will be woken up at 3 o'clock in the morning with a hypoglycemia, and you have to run to the patient's house, you have to take him to the hospital. The patient will come and complain that he's putting on weight, and perhaps that is putting an extra, additional burden of insulin resistance. So these are the questions the doctor needs to understand first, and then have to be ready with the answers. And finally, of course, the cost part of it, and the attitude part of it. The starting of insulin is usually the last resort. People say that the patient's attitude. People say that give me a try, give me an honestly, some time. Let me try one more month. But where we know that he's completely dehydrated. I mean, in terms of dehydrated cells, is deinsulinated from his beta cells. There's no insulin, yet he wants to try. So we have to be soft, very tender, and tell him, okay, we'll come back. And then we show that once he has gone up, or his sugar numbers are not settling. So then perhaps you will, from the process of DABDA, denial, acceptance, denial, anger, bargaining, the DABDA. And the fourth is, Cheryl, what's the fourth one? Denial, anger, bargaining. Acceptance is the last one. The penalty, the fourth one is, forgot. So this is the process, the Kubler process of how you adjust to a grief situation. So the fourth one has something, I think Cheryl will find out and tell me. So you go through that process and finally you buy to, accept that insulin will work for you. And, then the question is, I can't inject. How can I inject? There are no family members. So how do I do it? All these kind of vague excuses will come up, and you will, that doesn't really help. So what I'm trying to say is, oh, that was depression. So patient sinks into depression. And finally, with depression, if they believe that now they can't do anything, no bargaining with the doctor and educator anymore, they have to go into insulin, they will accept. So the fourth one was DABDA, was depression. So then injections will be painful. I'm all right. Insulin is not necessary at the moment. And then the cost factor also. And then this is a very common question they say, or statement. That once I start insulin, I have to remain on it lifelong. And I tell my patients, well, you started drinking water. When you switched off from your mother's milk, you straight away went to drinking water. Mother's milk is like the best possible food on earth and the best taste. And after that, you went to insipid water and you didn't revolt at that time. You're still drinking water. As I speak, I have a gulp of water. Insulin is like that. Why do you take insulin as your enemy? It is your friend. It will do all the good. You will never ever wish to come out of insulin. So these are the explanations that a doctor has to give to the patient. The patient's all the feeling of he's very hassled, the hypoglycemia, monitoring, social embarrassment. You're going, sorry for the spelling, going out and taking a jab in the public. Whether you have a refrigerator in a home or you're going to somebody's fridge or you have an earthenware. We have our beautiful Archana, who has made so many innovations in our country, and she's known for that. People who are traveling a lot, how do they store their insulin in the food pack? And whether they'll ask that these myths there you have, that you have insulin pills, you have insulin patches. I will go to that and let me wait for some time. They're just around the corner in the market. So these are the questions that we commonly face. We face that the families also give up, that they will become habituated. They are habituated to drinks and smoking and all other vices, but when they're habituated to insulin, that's a big question. And they might think that no other treatment is there. This is the last option. So this is the last, nail on the coffin, and you're about to raise the coffin on your shoulder. It's not that. So who will inject my insulin? Or there's no family member. Let him give him a chance. Give him some time. He has just eaten a few sweets in the past few days. He went to a marriage party, and then because that's the reason for his high sugar numbers. So these are all the excuses. And we need to actually understand, we need to simplify the insulin regimen. We need to start with small dose. We need to actually calibrate the dosage with the food and the exercise pattern. And we need to actually avail the support services that we generally have in our kind of a setup. But I think every person who aspires to treat a person with diabetes should have a ready, reckoner of an entire team, a multi-team approach of an educator, podiatrist, everybody that entails to give the best outcome for a diabetes person. We need to be ready with that. We need to know about hypoglycemia occurs also with OHA. And if they occur with OHA, the oral hypoglycemics with long half-lives, they will suffer more. They have to be admitted. Perhaps with insulin, you may not. You'll have 2-3 bouts of glucose and you're off it. But when you're on a tablet and you go land in hypo, you have to be admitted because these are long-acting ones. Once you start feeling better and you think you're ready to go home, you might again crash with another hypo because that effect is long-lasting. You have to reassure the people. You have to reassure the family. You have to make them recognize these early symptoms of hypo. Have clear plan of action as you sit with the person with diabetes for the first time. So start low and go slow is the ideal mantra for avoiding hypo. And the patient barrier is, you have to reassure that the patient, as Cheryl was saying, these 32G needles effectively on an abdomen is just painless. I tell you, it is not virtually painless. Only because we appreciate that there would be pain, there is a reconditioning in the mind which triggers our brain to tell us that there will be a pain, anticipatory pain. Actually, if you do that, there will be no pain. Frankly speaking, if you are given it unaware, the way I do it in my clinic, I just give a jab to the patient. Knowledge that has seen it, all the colleagues who have worked with me in my team and as my team in my clinics, I just, patient who was denying the insulin injection for 2 years, 3 years, and his kidneys were going downhill, all the other organs were getting complicated. The one shot, and the patient looks up to you and says, is there any needle there? Then I bring it out and say, what is this? Oh my God. And I've been waiting for this for the last 3 years, and all my numbers in different organs, they have just given up. So this is how you do it. You do the ice-breaking ceremony. I call it the ice-breaking ceremony, like the rice eating ceremony on the first day in your clinic across the table, on the table. Making injections nearly painless and pain-free is important. So you have it in the room temperature. The temperature has to be brought down. Bubbles. The spirit has to be evaporated. If you are giving spirit, I don't use spirit. Have the best relaxed set of mind. You need to really penetrate the skin very quickly. We have done that trick very well. We need to understand the direction of the needle. We need to have a new needle and talk about how many needles. There are not more than 4 jabs with one needle. Lancets are very there's a silicone coating, and they take a fold. So the role of treating physician is, of course, talk about the pathophysiology, talk about the role of insulin, talk about the OHA limitation, that they will not work if they're left in the cells. Talk about the complications. If you are really want to make them afraid, make them afraid with the complications, the cost of the complications, the loss of the organs. And don't use insulin as a threatening. Use it in such a way that they will come forward and ask and beg for insulin from you. That is the right way, I think. So let us help and the patient decide their own choice of what kind of insulin will work for him, whether it's a basal plus an oral like a BITS therapy, or whether it's 2 premix, or maybe in these type 1 cases, how often we have these premix because of the affordability issues, and of course other constraints at home. We also, this is not the right method, but in our practice, 10% of the people who just can't afford, we also have to give them premix insulin. Though we hate to give it, yet we make sure that we make it up with regular monitoring and kind of decorating the plate method, as Cheryl would call it, in such a way that the 70% premix actually is taken care by such and such meal, and then one rapid acting at night with a little bit of more carb. So we are doing that. I mean, the way we do it in our pump, the way we do our dual wave and square. So we do it here also in our own way. And that's actually the trick of the trade, how you have done it and how you're confident to do it with time. So empower your patient to have the desired glycemia. These are the barriers. The efficacy and safety is one section where you have all these problems, the barriers in management, then the convenience and the lifestyle, and then you have the education part of it. So the convenience and lifestyle is inflexibility of the regimen, that the regime that we write. People find it very difficult to have meals in between. People who travel and have busy lifestyles, they have problems. So what we do is now we have these suggested solutions where effective monitoring of the patients are done. Patient-centric approach is talked about. Formulation of patient wallet-friendly recommendations are done. Socio-cultural factors are talked about. The office, the friends, they are all motivated. So a lot of motivational skills are given into it. And in education, the primary care physicians need to be really thoroughly educated, and we need to have much and more courses. We need to have we see low referral to endocrinologists. the GPs started practicing diabetes, and that is not particularly right. They are not very well qualified. So we need to have, popular figures and community leaders who can talk about the awareness programs like Azad sir is doing in Bangladesh. He's got roped in, big names who are actually popularizing the role of quick insulin delivery and regular monitoring. We need to sensitize the mass media. We need to have uniformity of content across the country, whether it's RSS Day, whether it's Diabetes India, whether it's Diabetes Association of India, whether it's Day. We need to have an uniformity of the understanding of how we can have a patient-centric, family-centric education program and handhold the patient well. So basically, it is education support with the team and the shared decision making that is most important. And spreading awareness about diabetes in India will therefore require a large outlay of resources and efforts to succeed. I will end this talk with these barriers and solutions that burdensome regimens, fear of injections, therapeutic inertia, negative appraisals of insulin, poor communication, side effects of insulin are there. But there is also the outer ambit, that the gray area, the floating sphere outside, where diabetes self-management education, diabetes self-management support system, either through the mobile apps or through improved devices of insulin delivery, support from psychologists, nurse-led management, specialist feedback, improved therapies, they can occur. We know that these are the levels where patient, system, physician can engage. This is the stage of inertia. These are the possible solutions in different areas: fear of hypoglycemia, in fear of weight gain, in the burdensome regimens, where how to do the fixed ratio combination, how to do a basal and a liraglutide or a GLP-1 RA combination, how to flexibly arrange your dose with lower day-to-day variability. The poor communication, where the stepping up model, it's a fantastic model which is there in the in New Zealand, and they are doing very well. They have this treatment pattern where they talk about the effectiveness of the nurses coming into primary care, normalizing the insulin initiation for type 2 diabetes, and that will lead to improved glycated hemoglobin. So they had around 250 odd type 2 diabetes persons, and that involved a theory-based change in the practice system and their reorientation in the roles of their healthcare professionals. So it was not a doctor, it was a nurse who came into the picture, and their endpoints were to look into, when they transition to insulin, how quickly and how well they achieve the A1C and how long the A1C holds good. What were the changes in depressive symptoms? What were the problem areas in the diabetes scale? And the generic health status, the quality of life that we talked about. Everything improved with this stepping up model. So we can, because this is the year dedicated to the nurses from the idea, this was a time when we could have actually done this for the education of the nurses, and that could have actually changed the milieu of the ailing world. Then, of course, we have severe psychological insulin resistance. We need to have psychologists hand in hand, the anxiety, depression, the lack of time and resources for GPs. And finally, I'll come to how we do it. And this is absolutely real life story. This is where I show this, how we initiate and maintain. This is 7th December 2016. Look at the A1C. This is Apollo prescription, 14.2. Put him on insulin right away, straight away. Told him the importance of insulin at that point. Look at this, my right dose. And I decided with my patient and my educator to start on a given numerical. And the numerical will value every day, almost by the hour. And this is 27th January, just barely, 1.5 months, the A1C is 6.8. So we don't wait for 3 months, as we were taught in schools for A1C, because we know that 50% of A1C conversion is from the, dead RBCs dying and the quick, better ones, filling up the space. And if the better ones are good, then the numbers 14 can become definitely 6.8. And this is how we do it. We regularly do a titration at the SMBG, and all the educators, the angels, take care of that. And they hold good. So the patients also remain from 16. This is another patient, 2016, August 11.1, then December 5.1, 2016. Then it was then it was 17, again 1 year 6.1, 18 5.3, and now 19 it is, again it's still maintaining within 6. So they continue and they continue. This is the gentleman that I'm talking about. So we started with him with 10 units, and the 10 units, I don't write 10 units, I'll write 10 and then across it, and then a question mark would be there. He started like this. He slumped almost to his feet. He said that he's given up on life. He was having all the oral tablets in the world he knew. And then, now he looks like this. He wants to really enjoy his life. A police officer of repute. This is a type 1 who came with ants in the pan, not in the pants, but is on his glans. So I retracted his foreskin of the penis. There were 3 black ants dead, stuck in the penis, not the red ones. So he never found that. But he was saying that there was some irritation on the glands. And that was because of the dead, carcass of the dead ants, perhaps releasing formic acid as well. So when he came, these were his numbers, 17.7. And within 3 months, not a very rich, not an affordable boy. So I sponsored his insulin. And now he maintains at 6.5. Now Cheryl and everyone, I started with him at about 30/70, and that was on a general, regular insulin and an NPH. And the dinner was a rapid acting, an analog, and nothing in between, because he is an athlete and he goes to school, and he was not confident about doing it the school way. But what I did the first day was I put him on this, and then 7 days we did the optimum titration with his food, and his food was puffed rice and more of carb. He's from a local suburb. And look, this 7 days and the next 7 days when we intervened. So look at this drastic change, and this is for the real. So this is very recently COVID. This is COVID time. This Murshidabad, 26/4/2021. His 11.7, and we did and his son was very tech savvy. So my dosing, and every time he used to give him the meals, he used to take a picture and give it on my phone. And my educators worked well on this, and we now got his sugar number to it is how much? It is not even 1 month. It is before 1 month. It is 7.2. And this educator happens to be the dear niece of Norishda, because she is now idle and she is doing this for me. And the person I take this opportunity, that the insulin pump that was suggested to Norishda was not me, but the educator, whom I call the educator. So, and I believe, all of you who are educators, as patients, as educators per se by training, and of course, as doctors like us, we are hardly anything but, but educators, unfortunately. We need to really gear up and become the best of educators if we need to know diabetes well, and if we need to really understand insulinization. 100 years have gone, yet we are not very sure about the whole mechanism, I'm sorry to say. Let's change this. Cheryl, over to you. Thank you. Jai Ma.
Thank you so much. That was truly, truly wonderful. And, we saw how, the teamwork really works well. So yes, insulin, but also the teamwork and the doctor and the diabetes educator, the dietitian working together, keeping the person with diabetes as the center and helping him or her achieve her health goals. And I think so well covered in terms of barriers and challenges. I think that is something that we all deal with day in and day out, because people are scared of insulin initiation, and I think that is one role that we have to play in terms of educating them and telling them that insulin is safe and insulin is a life savior, and only insulin can save a person, or a person with type 1 diabetes. If he wants to lead a normal life, a good quality life, then insulin it is. So thank you so much, Dr. Basu, for this. And if anybody has any queries or questions, or wants to share anything, please feel free to put it in the chat box. And now I'd like to invite Ankita, who's going to share her journey of living and winning over diabetes for the last 20 years. And like Dr. Basu said, that she's corporate professional doing very, very well in her career, and nothing has stopped her from her professional life. And she's a wonderful example of how you can live happily and successfully with type 1 diabetes. So over to you, Ankita.
Yeah, hi.
Hi, Ankita.
I am visible.
Yes, you're visible and you're audible.
Okay, yeah. So I don't know, like I mean, thank you for that introduction, but I'm kind of speechless here. I do not do talks because I'm not good at this, and there are so many knowledgeable people. I was kind of enjoying the interaction. So any which ways, I will talk about my first tryst with insulin. So it was as the doctor said that it was I was in coma, and it was, I think, 7th or 8th day after coma, and I was still in the ICU. And up until that point, the nurses used to come and used to inject the insulin. So I had this, like, this insulin is there, and there's diabetes and all of that is there. It didn't really register. I knew that it is happening, and it was there, but it didn't really register that. So on that 7th or 8th day, I think that sister came up to me. She gave me that injection, and she asked me to inject it myself, because she said that you have to do it for the rest of your life. So to start it, and I was so scared. I mean, I was not scared because of my fear of needles. That was not there, because by that time I have been pricked innumerable times, and I was quite okay with the pricking of the needles, the sensation of the pricking of the needles. But I was scared. I mean, I was scared of this very fact that maybe I'll do it for my entire life, and I don't know what I was scared of, but I was very scared. So I was so scared that I actually dodged it. I told her that I'm not feeling well, and I will do it from the next day. And for that entire day, I kept on thinking, as it is in the hospital, you don't have much to do. So I kept on thinking about, I don't think I have shared this. I don't think Dr. Vasu knows this, but my very first memory of him was, he coming to my bed and talking and giving me a speech of how my lifestyle is going to change after this, how everything is going to, everything is going to shake up and everything is going to change and all of that. And to be very honest, I really didn't understand. I was like, I mean, I understood what he was saying, but I didn't follow him. So I was like, why is he making a big deal about it? It's just diabetes. And I've seen my father with diabetes. I mean, he has type 2. So I've seen him have some medicines and not eat a certain category of foods. And I said, it's fine. I'll have some medicine and I'll not eat certain category of food and it'll be sorted. So why is he making, a big deal about it? But I was not very familiar with him. So I kept quiet. And it was on that day when, the sister came and gave me that injection. And I was like, I started thinking that, no, my life is indeed going to change. I mean, that was, as correctly said, that insulin is life. But I would, in my case, I would like to say it is also an awakening. I mean, this was the first time it hit me that what has happened and how things are going to change. There'll be a lot of things that I have to unlearn, and there'll be a lot of things that I have to learn. And I would say, to be fair, I would say that it was an uphill task to bring that discipline or bring that regime into my life. But over the years, I think, I've come a long way from the person who, who was scared to even hold that injection and think of injecting myself, to someone who doesn't shy away from taking injections publicly now. I mean, be it on a beach or in the food court of a mall, I do it publicly with, eyes staring as if I'm doing drugs, but I do it. So that's I would say that's my tryst with insulin. I have made a lot of mistakes because it was not easy. This trial and error. No, I mean, there are books on which will talk about the technicalities. I think you all know it better than me. So which will talk about the technicalities, those sensitivity ratio, this, that, all the calculation that we do. But it's not it doesn't work for everyone the same way, right? So there were mistakes. I have made mistakes. I have learned from it, and I think now insulin and me are friends. We don't give each other a tough time. So it's very important, I would say, for a diabetic to be friends with insulin, because ultimately it is something which is going to keep your numbers under control. So it is very important that you know make peace with it, and you are at ease with taking of this insulin and with the numbers and everything, because we continuously we go out, and there are days when I have a pizza, there are days when I have an ice cream or a pastry or stuff like that. So I need to know how to tweak around those numbers and all. But yeah, I think it turned out pretty well. There are days when I feel tired, of course, with all the calculation that goes on. But then that is life, and I do not have any regrets. I'm perfectly fine with accepting it and working with it. I'm okay. So I would say life has been good. I mean, I won't. I mean, there are nothing that. I mean, there have not been anything that I wanted to do, but I couldn't do because of diabetes. That was never the case. That was not there. And I think we were talking about from doing a lot of things, but in some cases, it comes from a good place. Like they are thinking that they like when I used to dance. Okay, so after all this incident, when I went for my dance class the first day after a year or two, when I went for my dance classes, my dance teacher was so scared, and she loves me. I mean, I have been dancing from when I was a kid, since when I was a kid. So she loves me, and because she loved me, she was like apprehensive, like whether I'll be fine or not, what will happen. So that unawareness was there. She didn't mean it in a bad way, that I understand, because she meant it in a very good way, whether I'll be able to go along with it or not. So yes, unawareness is there, but it is not always in the discriminating terms. There are. I mean, I of course agree that there are a lot of cases where it is in the discriminating terms. I myself have faced it. I face it even today. So I don't get bothered. That's a different thing. I have learned to overcome all of that and turn a blind eye, or sometimes answer back when I can. But yes, but at times I think it comes from a good place. But the I would say the root of that is because of the unawareness about type 1 or diabetes in general.
Thank you so much, Ankita. I think it's wonderful to have you share your journey. And
I just want Ankita one question.
Thank you so much for coming on a Sunday evening and taking out time to interact. Yeah. So I'll hand it over to Dr. Basu now. I think we're running a little late, so we have
just one question to her.
Next speaker.
Sure. One question is, during her days, the last 20 years, we did not have much role of a diabetes educator in this city. Yes. So I think that would that be a challenge for her, or because I was very busy as a practitioner when I saw her for the first time. I was very, very busy. And I don't think I really put in that time and effort to her the way I do it now. But I think she deserved more. So, but does she feel that?
No, I think you gave enough attention. I don't feel that, but coming to your question, that yes, educator does play a very important role. I didn't have it when I started off. So there were a lot of things that I had to learn myself. I Googled, I read books and stuff. That I did, but I don't think, I mean, I got enough attention. I think I got more than enough attention.
We have fights, Ma. We've never at ease with each other. So we used to always shout, fight. So now, of course, she's my mother. So
that's a very beautiful relationship. I think that's so important, And so great. So thank you so much, Ankita.